Hello, everybody. I'm Steve Silverstein, the Associate Chair for Research in the Department of Psychiatry. And welcome to Grand Rounds for today, which is the 2022 Collier Lecture. Our presenter is Kim Mueser from Boston University, and the title of the presentation is Treatment of Post-Traumatic Stress Disorder in Persons with Severe Mental Illness. Before I formally introduce our speaker, I wanted to just mention a few housekeeping items. One is that everybody's microphone and camera will be off for the duration of the session today. If you have questions, and we hope you do by the end, please write them in the Q&A panel in the bottom right portion of your screen, and I'll read those to Kim at the end of the talk in the last few minutes. Also, it's very important to get everybody's feedback at the end or after the presentation. Steve Fasone will post a link in the chat box near the end, but make sure not to use the chat for anything else during the presentation. He'll also send a link at the end that you can use, and then tomorrow an email will be sent out also with the link to the post-presentation evaluation form. All right, so now I'd like to introduce Kim Mueser, who is my old friend and colleague. Kim is a clinical psychologist and professor at the Center for Psychiatric Rehabilitation at Boston University. He's also the former executive director of that center. Kim received his bachelor's degree from Columbia University in New York and his master's and PhD from the University of Illinois at Chicago. He began his faculty career in the Department of Psychiatry at Drexel University, then later moved to Dartmouth University Medical School, where he was from 1994 to 2011, before moving to Boston University. Kim's clinical and research interests include family psychoeducation, the treatment of co-occurring psychiatric and substance use disorders, psychiatric rehabilitation for serious mental illnesses, and the treatment of PTSD, including in people with serious mental illness, which is what we'll hear about today. Kim also has many other interests. He's an amazingly well-read person and a marathon runner as well. Kim's research has been supported by a number of places for many years, including the NIMH, NIDA, SAMHSA, and the Brain and Behavior Research Foundation, among others. He has over 400 publications, including 10 books and treatment manuals, and has served in many editorial positions for journals, including Currently. Kim has also won many awards, including the Armin Loeb Research Award from the United States Psychiatric Rehabilitation Association, and the Trailblazer Award from the Schizophrenia Special Interest Group of the Association for Behavioral and Cognitive Therapies. Now, in my view and many others, Kim really is a trailblazer. And one of the things that's most impressive to me about his work is that he can develop very user-friendly interventions and manuals that are easy to use by clinicians, and then at the same time conduct very sophisticated, large-scale treatment studies of their effectiveness. His work really does represent the best aspects of both the biopsychosocial model and the scientist-practitioner model. I also wanted to end this by noting Kim's encyclopedic knowledge of the psychiatry literature, which anyone who knows him has discussed at some point. As I've said before, you don't ever really need to look things up on PubMed if you know Kim Mueser. And with that, I'm going to let Kim take it away, and I'll see you all for questions and answers at the end of the session.
Thanks very much, Steve. I appreciate the wonderful introduction and the opportunity to be able to present to everybody. So you already know the title of my talk. Next to disclosures, I know it said I had no disclosures, but I do have to confess, at a distance, you can't appreciate this quite so much, but all of my clothes were made by my son, Jacob Mueser, who owns stores in New York City. He's a bespoke hand tailor suit and shirt maker with a store on 19 Christopher Street in Greenwich Village, and another one that just opened at 30 Rockefeller Plaza. So those are my only conflicts, so to speak, to present. So in talking about post-traumatic stress disorder, it's important to first define, well, what do we mean by a traumatic event? And the DSM-5 now defines a traumatic event as something involving a direct threat of death, bodily harm, or psychological injury to self or another person. The most common kinds of traumatic events experienced include rape or sexual abuse, combat, accidents, crime, assault, natural disasters. We should also mention man-made disasters or mass acts of violence, such as the current war now in Ukraine, the unexpected death of a loved one. There are also traumatic events that are unique to the experience of severe or serious mental illness, and those may include psychotic symptoms, which can be terrifying when first experienced, such as hallucinations or delusions. Involuntary treatment, such as being involuntarily hospitalized or put in a seclusion or restraints, or being threatened in an inpatient setting. It may also well be psychologically traumatic just to be informed that you have a particular diagnosis or a serious mental illness, or to be exposed to other disorganized individuals for a first time. For the most part, my discussions of post-traumatic stress disorder today in people with serious mental illness are going to focus on the common traumatic events that are experienced in the general population. There is a growing literature in terms of the treatment of post-traumatic stress disorder related to unique experiences such as psychotic symptoms and involuntary treatment experiences, but we're going to be focusing more on the basic PTSD as related to events such as exposure to violence in childhood and adulthood. In the general population, between 36 and 81% report experiencing a traumatic event. In the National Comorbidity Survey, individuals between 15 and 54 of individuals between those ages, 60% of men reported exposure to a traumatic event, 51% women, and 17% of the men and 13% of the women were exposed to 3 or more events. Now, the important thing about people with serious mental illness is that the rates are simply much higher by any stretch of the imagination. First of all, trauma and adverse experiences in childhood are well known to increase the risk of developing a serious mental illness, a broad range of different mental illnesses as well. And we also know that once people develop a serious mental illness, they're also more likely to be traumatized. And we know that when people have a psychiatric condition, that the exposure to a trauma, such as a natural disaster, tends to have stronger psychological effects. A person is more likely to meet criteria for PTSD than an individual exposed to that traumatic event who doesn't have a serious mental illness. Multiple traumatization is common in people with serious mental illness, and a history of trauma is associated with more severe symptoms and distress. And service users report that traumatic experiences are important, but typically neglected in treatment. This is a study going all the way back to 1998, where we surveyed exposure to traumatic events in 4 samples of people with serious mental illness, 2 inpatient samples and 2 outpatient samples, with 2 of the samples being in New Hampshire and 2 of them being in Baltimore. And you can see, if you look at the red marks are traumatic events in childhood, and the green are those in adulthood. So if you just look at sexual assault, you can see rates of 50% childhood sexual assault, meaning like abuse among women. Among the in childhood among women, and even higher in adulthood among women. Among men, there were still almost 30% rates of childhood sexual abuse in childhood, and a little bit lower, around 20-some% in the men. And so these are just some of the indications of the very high rates of trauma exposure in people with serious mental illness. We gave up trying to count actual traumatic events long ago. And when we look at different indices of trauma exposure, we look at exposure to different types of traumatic events, such as physical assault, sexual assault, accidents, and so on. So sometimes, at least, the question comes up, why focus on PTSD? And I say this in part because there is a growing recognition and interest in the development of trauma-informed interventions that recognize the important impact of trauma on the lives of people with serious mental illness, and probably have as their primary goal to avoid the all too common re-traumatization of individuals. But it still leads to the question of, well, why focus on PTSD in particular? And there are several reasons. First is that PTSD is the most well-established psychiatric consequence of exposure to a traumatic event. Second is that there's a moderately high prevalence in the general population, around 7%, and even higher prevalence among vulnerable populations, like people with serious mental illness, but it's frequently undetected. Post-traumatic stress disorder is related to increased rates of distress and acute care service utilization, like hospitalizations. The assessment is relatively straightforward. And in fact, right now, I'm going to tell you, because I don't have another slide on it, that one of the very simple ways of screening and identifying people who may have post-traumatic stress disorder is a simple checklist called the PTSD checklist, otherwise known as the PCL, which has been adapted now for DSM-5, and so it's called the PCL-5. And there are a number of other screening instruments that are very good at picking up people who are likely to have a diagnosis of post-traumatic stress disorder. Psychological treatments have been shown to be very effective in the treatment of post-traumatic stress disorder, and pharmacological treatments are also beneficial. So that's why I think it's important to focus on PTSD and to provide it as a treatment option for people who have serious mental illness and PTSD, because it's common, it's associated with high levels of distress, it's easy to assess, and it's pretty straightforward, actually, to even treat. That's what I'm going to be talking about more today. For people who are not familiar with the symptoms of PTSD, the DSM-5 symptoms include, in addition to exposure to a traumatic event, 4 clusters of symptoms. There are intrusion symptoms, intrusive memories. These are kind of thoughts or images of the event that pop into the person's mind when they're not thinking about it. They might be triggered by something. It can also include flashbacks, which is the actual re-experiencing momentarily of being back in the moment of the trauma. And nightmares are another kind of intrusion symptom. Avoidance of trauma-related stimuli is a core symptom, avoiding memories, situations related to trauma. Over-arousal, as reflected by hypervigilance, difficulty sleeping, anger outbursts are common symptoms. And negative alterations in cognition or mood, such as inability to remember parts of an event or persistent negative feelings or detachment from others. There are other common symptoms of PTSD that are not incorporated into the diagnosis. Those include depression. Depression is the most common comorbid disorder in people with PTSD. Guilt, suicidality, the risk for suicidality or suicides attempts and succeeded suicides is quite elevated in post-traumatic stress disorder, probably comparable to rates that are seen in major depression, bipolar disorder, and schizophrenia. Substance abuse is increased, and there's evidence that you get hallucinations and even mild delusions. You can get this in primary PTSD, even in individuals who don't meet criteria for schizophrenia or for psychotic depression or bipolar disorder. There is, for example, very interesting literature on the experience of hallucinations of a lost loved one as part of the bereavement process for people in Japan. And so, although it's not recognized in the DSM-5, there is a literature showing that severe PTSD is associated with mild psychotic symptoms, even in the absence of another axis 1, a disorder that could explain those symptoms. I mentioned that rates of post-traumatic stress disorder are elevated in people with severe mental illness. This is just a sampling of around 11 or 12 studies. The majority of studies indicate that in multi-episode samples of people with serious mental illness, that the rates of PTSD vary usually between around 25 and 40%. They're a little bit lower in first episode psychosis individuals. They tend to be the very highest among people with major depression and with borderline personality disorder, where we typically see rates over 50%. And at the same time, these rates of post-traumatic stress disorder are typically not documented in individuals' charts. They're beginning to get more documented now with greater recognition of the effects of trauma, but frequently they are simply not documented at all. A number of years ago, in trying to convince people about the importance of both assessing and treating post-traumatic stress disorder, We developed what might be described as a Lieberman-esque, in honor of our departed friend and colleague, Bob Lieberman, passed away last summer, a Lieberman-esque stress vulnerability model that posited that PTSD served to both directly worsen the course of serious mental illness through symptoms like re-experiencing symptoms and avoidance, which would lead to increased experience of stress and potential reductions in the experience of social support, as well as indirect effects of PTSD on worsening the course of illness, such as contributing to substance abuse, which can worsen symptoms, interfering with developing a good work alliance, which could interfere with receiving good illness management services, and so on. So in addition to the high levels of distress associated with post-traumatic stress disorder, there are reasons to think that treating this disorder in people with serious mental illness might improve the overall course of the mental illness. But what do we know about the treatment of PTSD in the general population? Generally speaking, there are two psychological interventions that have the preponderance of evidence showing that they are more effective than other interventions. Although I will say that there is a growing number of other interventions that do have an evidence base supporting them. So it's not really as though one is even limited to these two interventions, but these two tend to have the strongest support. And those include exposure therapy, which refers to prolonged exposure to safe but anxiety-provoking trauma-related stimuli. And this includes imaginal stimuli and in vivo. So in terms of imaginal stimuli, what we're really talking about is the memories that people have of a traumatic event. And when you're doing prolonged exposure, what you do is you focus on one memory at a time, and you have the person go over that memory, talking about it out loud, and over the memory again and again. And essentially what happens is that the initial anxiety associated with the memory habituates with the repeated exposure to it, in combination with the fact that bad, terrible things don't happen when a person retells a traumatic event. In fact, what happens usually is that the anxiety very gradually goes down. And so in the imaginal component of exposure treatment, you simply have people go over memories one at a time repeatedly until the anxiety related to it goes down. And sometimes you'll even make audio recordings of these and have people listen to them at home. And then what you also do is you identify actual situations in the environment that the person is avoiding because it reminds them of the traumatic event. And you create a hierarchy and work out with the person to expose themselves, to go into those situations and to stay in long enough until their anxiety habituates in those situations, starting with less frightening situations and working your way up the hierarchy. The other intervention is cognitive restructuring. And cognitive restructuring is really the core therapeutic element at the heart of cognitive behavior therapy. It involves identifying, challenging, and changing upsetting and inaccurate trauma-related thoughts and beliefs that are hypothesized to underlie PTSD. And that also involve incorporating the experience of trauma into the self. There are theories of PTSD as reflecting certain schemas, thoughts and beliefs about oneself, about other people, and about the world as influenced by a traumatic event, and are thought to contribute to the maintenance of PTSD symptoms. Interestingly, many of these schemas are not necessarily fear related. They're not necessarily that you can't trust another person or that the world is an unsafe place. Some of these have to do with oneself. For example, I'm a weak person, or I'm easy to take advantage of, or I have no life ahead of me. I'm damaged goods. Nobody would want me. So that's one of the reasons why cognitive restructuring approach may be useful, which is that it tackles more than just the prominent feelings of anxiety associated with post-traumatic stress disorder. And maybe especially useful when the dominant emotions experienced by people are not anxiety, such as when they're guilt or anger. Research on exposure therapy and cognitive restructuring in the general population shows that they are equally effective in a number of head-to-head comparisons. And interestingly, it also shows that when the two are combined, they're not more effective than either one when provided alone. There is another intervention that is fairly well known, eye movement desensitization and reprocessing, also known as EMDR. And the evidence does indicate that EMDR is effective as well. EMDR contains elements of exposure in which people are taught to bring forth into their minds and to contemplate a particular aspect of a traumatic event. And it also involves cognitive restructuring components, in which people are encouraged or helped to think about these events differently. So I don't look at EMDR as a fundamentally different intervention proper, although it certainly is a different way of packaging a treatment for post-traumatic stress disorder. And to its credit, it's brought a fair number of people into treatment for dealing with their PTSD. And therefore, I am less hostile to it than I used to be, as I was many years ago. I now think that there's many, many different routes to the treatment of traumatic experiences. And one has to have an open mind in terms of whatever gets somebody into treatment. However, there are problems with research in the general population when it comes to the inclusion of people with a variety of disabilities or other comorbid conditions. In particular, most studies of post-traumatic stress disorder in the general population have ruled out people with serious mental illness because of exclusion criteria, such as ruling out people with psychosis, with suicidal ideation, with cognitive impairment, with people who are either currently receiving medication or have had medication changes, or with severe medical problems. And in fact, a number of years ago, a consensus statement was made that pure PTSD is unrepresentative of the typical presentation of treatment-seeking individuals with trauma histories. And in this way, I think PTSD is actually quite a bit like substance use disorders, in that their presentation as a solitary disorder is relatively uncommon. That comorbidity is more the rule than the exception, with both PTSD as well as a substance use disorder. As part of this consensus statement, Spinazzola and colleagues, 2005, said, "True advancement of the field will require a deliberate process of evaluation and adaptation of efficacious treatments with less restrictive and more clinically representative PTSD samples." And I will say we're very delighted when this consensus statement came out, because we had been working to this end for about 5 or 6 years already at that time. And the bulk of what I'm going to be presenting today is really about an intervention designed to do exactly that. As it turns out, many people want much more specialized interventions for people with a history of childhood sexual abuse, interventions for people with schizophrenia or psychotic symptoms. And yet we feel that the greater need in the field is for interventions that are in fact contain common intervention components and are broadly applicable with the skill of a clinician to somewhat different presentations and even different patient populations. And so what I'm going to be presenting today is about research on the treatment of post-traumatic stress disorder in people with severe mental illness. But the same treatment model is one that we've used in people with addiction, in adolescents, in people receiving primary care, and that it's also being adapted for people in lower and middle income countries. So I think that there is a lot of potential for general interventions based on the principles of evidence-based practices for addressing the needs of people with post-traumatic stress disorder coming from a variety of different populations. So the program that we developed, we decided to focus it on cognitive restructuring and not on exposure therapy for several practical reasons. First of all, some people do refuse to participate in exposure therapy. And after all, avoidance of trauma-related stimuli is a defining criterion of PTSD. So it only makes sense that it's going to have at least some degree of lower acceptability to at least a subgroup of individuals. And there is evidence indicating this. As indicated before or implied, there is actually evidence showing that exposure therapy is somewhat less effective when anxiety is not the dominant emotion. So for example, when the dominant emotion is guilt or shame, anger or depression, it may be less effective. And the reason is probably that the primary mechanism underlying the effects of exposure therapy is assumed to be habituation associated with prolonged exposure. But habituation does not occur when it comes to feelings such as guilt and shame or anger. It's really specific to anxiety. In addition, there are concerns about re-traumatizing a vulnerable clients by having them participate in exposure. I should say I don't actually believe in the validity of this. There's good evidence that exposure therapy can be done in people with serious mental illness. Very good research from a large Dutch controlled study of people with psychotic disorders that exposure therapy can be provided. It provides therapeutic relief from PTSD symptoms. It does not re-traumatize individuals, and in fact, it reduces the likelihood of adverse events that may occur, such as suicide attempts and so on, in individuals' lives. So when I say concern over re-traumatizing, really what I mean is that even though the data doesn't indicate that exposure therapy does re-traumatize individuals, a lot of people are worried about that and they're afraid of that. And after all, it is a vulnerable population, people who may be at risk for suicidal ideation and suicide attempts. And so concerns about stressing individuals out, potentially increasing the amount of stress on them by reviewing traumatic events, is at least a concern when it comes to dissemination of any trauma-related intervention. And the last reason is that there is good experience, broadly speaking, in the field of using cognitive restructuring in a wide range of different populations, including people with schizophrenia and other severe mental illnesses, such as in CBT for psychosis. So this is a picture of the book that describes the general treatment model, published in 2009. Unfortunately, it's out of print right now. This is a more recent book, but lays out the same basic treatment program for people who have been a victim of a recent disaster or mass violence and have post-traumatic stress disorder. This came out in 2021. So I'm going to very quickly run you down what the treatment program is about and a little bit on the research. So in terms of logistics, we developed a 12 to 16 week standardized CBT intervention. The primary focus of our research has been on providing it individually, although we do have experience providing it in groups. It's typically provided at local community mental health centers and integrated with other treatment components. And part of the intervention involves monitoring of symptoms, in particular PTSD symptoms, using the same PTSD checklist I mentioned earlier, as well as depression. And what we do is we monitor these symptoms at the beginning of the first session and every third session thereafter. And we both discuss the symptom level, whether things are getting better or not and how much, as well as incorporate information from these symptom ratings into treatment. So for example, you can get at trauma-related thoughts and beliefs if they're not presenting naturally by themselves later on in the course of therapy by discussing a particular symptom that a person has endorsed on the PCL, such as the recent experience of intrusive memories related to the traumatic event. We divided the intervention into a series of 8 different modules, and I'm going to quickly run down through them. The first is an overview, where we kind of provide an overview of the program, the different components and how they work. The second is, we used to call it a relapse or like an emergency response plan. And then we found out that we were actually stressing people out by calling it that. So we call it a distress response plan. And the idea is to identify indications that the person may be experiencing an increase in stress, which could also include an increase in symptoms, including things like suicidality or hallucinations, and coming up with a plan for both monitoring them and for responding to them in order to enable the person to remain in and complete the program. Then we teach breathing retraining, a technique that in the long run is thought of as an anxiety management technique, but we teach it as something that we want people to practice and get command over by practicing it every day in situations where they're not feeling especially anxious and over-aroused, in order to learn the skill, at which point they can begin using it to manage anxiety. It turns out it's possible that teaching the breathing retraining this way has more direct effects on PTSD symptoms than we had imagined, for reasons I will briefly get into when I talk about our brief intervention. We do those 3 modules of the introduction, the distress plan, breathing retraining in the first session. And of course, we follow up on breathing retraining in each of the next remaining sessions to try to make sure that the person is learning it as a skill. We then spend the remainder of the first session and the next 2 sessions on education about trauma and PTSD. We go through the different symptoms, we explain the nature of them, we help people relate them to their own experiences, we have different worksheets and things like that. And I think that the benefit of this is that education about PTSD provides a kind of an adaptive and a more acceptable and less distressing way of conceptualizing people's symptoms. Rather than thinking that that one is going crazy or one is bad or weak, you can recognize different symptoms as being part of a syndrome of post-traumatic stress disorder caused by a traumatic event, and that is common and not your fault. So I think it provides a more benign interpretation for PTSD symptoms. In Module 6, this begins with the 4th session. We begin the teaching of cognitive restructuring. And we have found it very helpful to divide teaching cognitive restructuring into 2 different skills. The first skill is aimed at helping people make the connection between thoughts, feelings, and behavior, the tripartite cognition, emotion, behavior triad. And then what we do is we introduce them to common inaccurate ways of thinking. These are often called cognitive distortions and so on, but it turns out people don't like having their thinking referred to as distorted. And so we had typically referred to them as common styles of thinking, although in more recent years, because a lot of people, when they hear common styles of thinking, like all or nothing, black and white thinking, or overgeneralization, a lot of people relate to them, but they're forgetting that these are common inaccurate ways of thinking. So nowadays we refer to them as common inaccurate ways of thinking. And we make this introduction to cognitive restructuring in the 4th session, at which point you can get people to begin trying to recognize when they're engaging in these common inaccurate styles of thinking. And the cue for engaging in cognitive restructuring as a self-management skill is the experience of negative feelings. If you have any negative feeling, okay, there's a thought associated with the feeling. There are common inaccurate ways of thinking. Is this particular thought that I've identified one of those inaccurate ways of thinking? If it is, how can I change the thinking to make it more accurate? That's the first cognitive restructuring skill that we work on teaching. We spend 2 or 3 sessions teaching this. We normalize common styles of thinking as errors that everybody participates in, elicit personal examples, but get people trying to catch them on their own and then practice helping them by going over homework assignments. We then, usually around the 6th session or so, introduce a skill that builds on the common styles of inaccurate thinking, but is a little bit richer. We call it the 5 steps of cognitive restructuring. And the 5 steps include describing the situation, identifying the strongest upsetting feeling, identifying the strongest thought or belief related to that feeling, evaluating the thought. And at this point, people are prompted to consider whether the thought might be a common inaccurate way of thinking, which is kind of a hint that there is evidence against the thought and it may not be accurate, but it isn't always the case. And then the last step is to take action. And at this point, they either decide whether the evidence supports the thought, in which case they change it, as in typical cognitive restructuring, or they may decide that the evidence does in fact support the thought, in which case they're prompted to develop an action plan. It's more or less like a problem solving for addressing the situation in which they're having an upsetting thought, and a calm evaluation of the evidence indicates that there's good reasons for being upset in that situation. So for example, a woman with a history of having partners in which she is a victim of domestic violence begins dating somebody. At a particular point, he's beginning to show a certain level of disrespect to her. She's anxious, is wondering if she's vulnerable to being victimized, and so does a cognitive restructuring, 5 steps on that. And instead of concluding that her thoughts are unrealistic, she decides, in fact, the evidence does support that there is a risk to victimization here. And so she develops an action plan, either breaking off, reading the riot act to the partner, or whatever. So I think that the richness of the cognitive restructuring approach, the 5 steps of cognitive restructuring, is that it doesn't assume that every upsetting emotion is in fact related to inaccurate thinking. And we have a worksheet for this, and we spend most of the remaining time on this. I realize I'm running out of time a little bit, so let me quickly run through some of the research on this. We've done a number of feasibility trials. There are 2 randomized controlled trials that we've done evaluating the CBT for PTSD program. And those are the 2 I'm going to focus on in a little bit more detail. And I'm not going to go into more detail from the studies listed here. I have sent a copy of my PowerPoint to Steve. We'll send to anybody else who wants, or you can distribute it among yourselves. And anybody who wants related publications, just let me know. The first study of the CBT intervention was done in New Hampshire and Vermont, and it compared CBT with treatment as usual in 108 people, 15% of whom had schizophrenia spectrum disorder, the rest who had major mood disorders. And then they all had severe, actually in this study, 75% of them had severe PTSD, according to the clinician administered PTSD scale. In addition to all of those diagnoses, 25% also had borderline personality disorder. The exposure to the CBT program was 81%. We defined exposure as 6 or more sessions. We did it at 4 different community mental health centers in New Hampshire and Vermont. It was done by expert level clinicians. And we had assessments conducted at baseline, post-treatment, and 6 months later. And the primary outcomes were on PTSD knowledge, trauma-related beliefs, PTSD, and other symptoms. I'm just going to show you 2 figures in order to move on to the next study. The first one is the average CAPS severity scores for the 2 groups. The CAPS is the gold standard when it comes to the assessment of PTSD, a structured clinical interview that systematically goes through PTSD symptoms. And what you can see is that the usual treatment condition improved over time, but that the CBT program improved considerably more than the usual treatment condition did. By the way, the usual treatment condition probably improved because for many people with severe mental illness, PTSD is a fluctuating disorder with symptoms coming and going in relative severity, and people sometimes meeting criteria for PTSD, but not necessarily other times. So if you get people into a protocol for that, you tend to get them in during a peak or during a higher period of their PTSD symptom severity. And so we're not really seeing treatment improvement effects in the treatment as usual group. Rather, we're seeing more of a regression to the mean, as it were, or more of a reduction from a high point of severity of the disorder. This is ratings from the Beck Depression Inventory, self-rated depression scale. And you can see, again, decreases in depression that kind of gradually go back up again for the treatment as usual group, but sustained reductions in depression that stay down and through the follow-up period for the CBT group. Now I'm going to talk briefly about the New Jersey CBT study. And this is the one I did in close collaboration with Steve Silverstein at University of Medicine and Dentistry of New Jersey. It was done at 5 sites conducted primarily in urban settings. Majority of participants were minority. PTSD treatment was provided by frontline clinicians. We compared the CBT, cognitive restructuring intervention, to a brief intervention that really included just the first 3 sessions of the full intervention. So it included the psychoeducation about trauma and PTSD, and it included the breathing retraining, but none of the cognitive restructuring. We assessed long-term functional outcomes, services, and costs, both at going from pre-treatment to post-treatment and 6 and 12-month follow-ups. We had a large sample, 201 individuals, 33% schizophrenia spectrum, 28% borderline personality disorder. To talk just a little bit about the inclusion criteria, and this is inclusion criteria for both of these studies. In order to be in either study, people had to be adults with serious mental illness, including either a schizophrenia spectrum disorder or major mood disorder, as well as meeting state criteria for severe mental illness. And they needed to have severe PTSD, as defined by a CAPS score, clinician administered PTSD scale, of 65 or more. We required that people not have a hospitalization within the past, I think it was 3 months, And we also required that people not have a suicide attempt within the past 3 months. Self-injury and suicidal ideation were allowed, and as it turned out, were relatively common. And then I've mentioned when the assessments were done. And here are the eligibility criteria, so we don't need to review them again. And the brief intervention, as I mentioned, was just 3 sessions, including breathing retraining and psychoeducation about PTSD. It was all standardized. We also had an accompanying DVD that had excerpts of a video of both clinicians and clients talking about PTSD. And the primary outcomes were PTSD, symptoms, diagnosis, knowledge, and social functioning. And then we had secondary outcomes like other symptoms. So what we found was that the PTSD outcomes were in fact found to improve significantly more for individuals who received the cognitive restructuring intervention than those who received the brief intervention. This gives the percentage of people meeting criteria for PTSD. You can see that it goes down in both groups, actually quite a bit, but it goes down significantly more for the group of people who got cognitive restructuring. And essentially, you see similar outcomes across all of the specific outcomes of PTSD, such as PTSD knowledge, symptom severity, and so on. In terms of secondary outcomes, there was some evidence showing that the people in the cognitive restructuring group improved significantly more in the global assessment of functioning over time. So there were, and in particular, there were more rapid improvements for people in the CBT compared to the brief intervention in overall function. Interestingly enough, there were no differences between the groups in depression or other symptoms. There were no differences in post-traumatic cognitions, which to me was tremendously striking, considering that one intervention had 8 to 11 cognitive restructuring sessions, and the other had 0 cognitive restructuring sessions. And post-traumatic cognitions is hypothesized to be a mechanism underlying PTSD symptoms. There are also no differences in overall quality of life, with both groups improving across all 3 of these outcomes. This is the effect showing some greater improvement favoring the CBT group on the global assessment of function. Now, what we decided to do is to compare the results of the New Hampshire study and the New Jersey study, because even though the populations treated, or the characteristics of the populations treated, differed quite a bit, one being more minority, one being predominantly white, one being more mood disorder, the other having a higher percentage of schizophrenia, the impact of the cognitive restructuring intervention was actually quite similar between the 2 interventions. And what we saw is that if you look at the change in the CAPS in the New Hampshire study, in the cognitive restructuring intervention, people improved 20 points on average. And in the New Jersey study, with the same intervention, they improved 23 points. If you look at treatment as usual, in the New Hampshire study, they improved 9 points, whereas in the brief intervention, they improved 15 points. So it looks to us as though there is at least some benefit being provided by the brief intervention as compared to services as usual. Interestingly, when we looked at the mental health costs, there were no differences between CBT and the brief intervention in the first 12 months of service utilization following participation in the trial. And then when we looked at cost benefit in terms of the relative cost benefit in terms of dissemination, what we saw is that the CBT intervention is more effective than the brief intervention, but at a relatively high cost, $33,000 per PTSD remission. And at the same time, the brief intervention has a lower implementation cost per clinician. It only costs about $1,800 to train a clinician in the brief intervention versus $6,100 for the CBT intervention. And the brief intervention is shorter in duration, so there's less cost in implementing it. And so the overall results of the cost analysis is that an investment in implementing the brief intervention would likely result in more PTSD remissions per year than an equal investment in the CBT intervention. I will say it was quite the opposite finding that we expected to find, but nevertheless, very interesting, I'd say. And so to wrap it all up, the CBT for PTSD program is effective in treating PTSD and related outcomes in people with serious mental illness. The New Jersey study showed that predominantly minority clients living in poor urban areas could benefit from the CBT program. Frontline clinicians could implement the program with good fidelity. Effects were sustained for a year. The cognitive restructuring component of the program did prove to be most critical to improving PTSD in people with serious mental illness. But the brief program did appear also to produce a significant benefit in PTSD and other symptoms. This is the only intervention to have been shown to improve PTSD in more than one randomized controlled trial. In terms of future directions, you can't get away from the fact or the implication that the brief intervention for PTSD looked pretty darn good and may well be an effective treatment. It reduced the difference in effect between the cognitive restructuring intervention and treatment as usual by around 50%, if you compare the New Hampshire-Vermont study with the New Jersey study. And there were no differences in the outcomes of the brief and the CBT intervention on non-PTSD related outcomes such as depression and other symptoms. In addition, not reviewing it here, but there were higher rates of completion of participants in the New Jersey study. It is, in fact, easier to get people through a 3-session intervention than a 12 to 15-session intervention, especially in sites where there are high rates of no-show. We've had other positive experiences in terms of replicating the promising findings of the brief intervention, which we now call BREATHE. And I can never remember what the acronym stands for, I apologize. But this BREATHE intervention has also been adapted to a variety of other vulnerable populations, including adolescents screened and identified as having PTSD in primary care, homeless individuals with serious mental illness, and individuals living in lower and middle income countries. And so there's a need to evaluate the brief intervention experimentally in a rigorous randomized controlled trial. With that, I will stop sharing my screen in order to take any questions.
Thanks, Kim. All right, very good. So we do have questions. The first question is, in this area of study, is there any assumption about the role of trauma in causing the SMI?
I would say that the assumption is that if the traumatic events happen before the onset of the SMI, they may have played a role in either, broadly speaking, increasing vulnerability to the severe mental illness, potentially specifically to contributing to the nature and form of the psychotic symptoms that are observed. So I'd say we are agnostic in terms of the exact role that it may play, but cognizant of the fact that trauma can certainly increase risk to severe mental illness, as well as sometimes shapes the nature of psychotic symptoms that people experience.
Okay, great. Another question is, has this ever been used in a forensic mentally ill population? Or what do you think the results would be if it was used in a prison or recently incarcerated group?
That's a great question. I love it. We've actually been working for the last couple of years on trying to essentially create the foundation for doing such pilot work in a forensic setting. We are working with a forensic psychiatrist in 2 correctional settings in the Boston area, and have been doing assessments of trauma and PTSD among individuals identified as having possible psychiatric disorders. Our interest and have laid out a basic plan is to follow that up with routine screening of trauma and PTSD, and then engagement in 3-session intervention. I'm convinced that the 3-session intervention really is the place to start for many places, and in the long run, I believe that a stepped approach or staged approach to the treatment of PTSD may be most promising for many people, in which you provide a brief intervention, evaluate, reevaluate, see where people are at, and then provide the more in-depth cognitive restructuring for people who continue to have persistent PTSD.
Okay, well, you just answered another one of the questions about the staged treatment model. Another question is, how young can you go with this intervention the way it currently is available?
We've done one pilot study, non-controlled, but open pilot study of the intervention with adolescents, I believe going down to age 13. And we also have a separate treatment manual for, it's called Treating Trauma in Teens. Mary Kay Jankowski is the first author of it. We've done one pilot study where the responses were very, very good with adolescents. And there are some advantages of the cognitive restructuring approach to a traditional evidence-based treatment for PTSD in adolescents. Very briefly, traditional treatment is based on exposure therapy. This is the Cohen model. It's kind of an adapted exposure therapy where the children or adolescents essentially write their story down. It's transcribed by a therapist, or they can write it down themselves. Some cognitive restructuring is thrown in, but it's primarily an exposure therapy thing. And when you have traumatic events that have come to light through, for example, childhood sexual abuse, physical abuse, there are certain challenges sometimes in exposure therapy because new information comes up, and then you have different reporting requirements and things like that. And so it can be very complicated. The cognitive restructuring approach gives adolescents more control over the therapy process. And so we do have very good experience in terms of this one pilot study treating a series of adolescents with the treatment program, but no controlled research so far.
Okay. Another question, I should say, this comes from Will Pigeon, who thanks you for your talk and sends greetings from a fellow former Big Greener. I have no idea what that is, but I'm assuming you do. Okay, Will's question is, did you have any thoughts on combined or sequence treatment where adding another brief treatment for a co-occurring condition or complaint makes sense?
I think that I'd be interested in knowing what other co-occurring condition Will might be thinking of. If I were to pick a co-occurring condition, I would pick substance use disorders. And I have certainly thought of it. We have not done it in a systematic sort of way. Whaley Liu, who Steve knows and I know and has worked with us for a number of years and is still down in New Jersey. She worked with us in the New Jersey and the New Hampshire PTSD studies, has studied the combination of CBT treatment for PTSD with supported employment, with the notion that helping people cope with trauma-related experiences may overcome some of the obstacles to seeking employment in this population. On the other hand, I know that unemployment isn't necessarily a comorbid condition proper, but it's an example of the combination of the approach to address more than one problem.
Okay, I think we have maybe time for two more questions. Well, let me skip to this one now. This is actually from Steve Lamberti. Is a brief treatment manual available?
Yes, just ask me for it. And anybody who wants to do research on it, I would be happy to facilitate it. We originally had a brief manual only that was that incorporated this video, but we've gotten a lot of feedback, and even though the video is pretty effective, it's only for kind of a certain group of people. A lot of people don't relate to it, and so the manual that we're using more often now is one without the video, and it's updated to have educational handouts corresponding to DSM-5.
Okay, very good. And this may be the last question. You know, so to do this approach that you've described, not having been involved in it myself, you want to have a trauma screening and then a trauma history screen and a PTSD symptom screen as part of routine clinical care.
Right.
And so could you say something about, you know, how easy is it, or what are the challenges are about getting to that point in a community mental health center?
Sure. From the screening of trauma perspective, What we did is we adapted a standard screening measure that was more extensive than we thought was needed to turn it into, I forget, it's 16 or 18 items where people simply indicate yes or no whether they've experienced this traumatic event. And then if they have experienced one or more, they're then prompted to respond to the PCL, that's the PTSD checklist, which is 21 items corresponding to the DSM-5 PTSD symptoms. And they indicate how much distress has this particular symptom caused you related to this event over the past month. There are different versions over the past week, over the past month. We typically use, I think, over the past month for screening. It takes about 10 to 12 minutes to administer the screen. It can be done by self-report for individuals who have good reading. It could be read by a computer program. It could also be administered by interview. And we've done this at this point literally for thousands. I mean, we did it for well over 1,000, I think a few thousand people in New Jersey, but we also did it for our studies in New Hampshire and Vermont and other studies. So we have tons of experience with it. You have to do a little bit of training of clinicians for how to do the assessment, just to make them feel a little bit, calmer and at ease, and to reassure them that all hell will not break loose when you ask people with serious mental illness about trauma. But it's a fairly easy trauma assessment to integrate. Probably the biggest challenge is getting the administrative support behind it in order to incorporate it into routine procedures. We do think it's important to get that administrative support, to incorporate a particular form for it, as we did in New Jersey, mainly by expressing the importance of identifying PTSD in order to inform treatment, as well as down the road in order to provide trauma-specific interventions. Once you get administrative support behind it, I think that the actual routine assessment of trauma and PTSD can occur relatively naturally with really very few complications to my knowledge. I'm not sure if I'm addressing all the nuances or things that you might think are important, Steve. So if there are other things about that we should elaborate on, just let me know.
Okay, well, no, that covered it. I think it's an important process to get that support and to do it. There are a number of steps, but it's really worthwhile. And I encourage that we do that here, as a matter of fact. And
yeah, I agree. And in fact, just to add, Steve, not only did we do it in the New Jersey study, but in the New Hampshire, Vermont study, at the 5 centers that we did it, we got them to implement, sometimes it wasn't necessarily the admissions, we got the clinicians to simply routinely, systematically evaluate trauma and PTSD in all of their clients. We got administrative support behind that. We went to different team meetings and so on. And the practical reason is that you don't know the nature of PTSD symptoms and the varied presentations of it and the like are that you often don't know that somebody has PTSD that you're treating. And I say this with all humbleness that I myself have treated people at times for months for disorders that I thought that they had, where I did not do the appropriate screening, only to find out that I was on the wrong foot and to be surprised by a trauma history and a positive PTSD screen where I least expected it. So I do think just to amplify your comment about the importance of getting systematic screening implemented in order to provide these services.
Okay, well, Kim, I want to thank you again for an information-packed talk. Very interesting. We're out of time. So again, thank you. I want to thank everyone for attending. Please remember to fill out the evaluation. Please also, people from the U of R, remember we have a 75th anniversary next installment on research next Tuesday night. And of course, grand rounds again next week. And I will see you all at those. So Kim and everybody have a great day.
Great. Thanks, everybody. Thanks, Steve.
Okay, take care.